Hi guys! So have you been told that you've got a Haglund's deformity in the back of your heel, or a heel spur that's causing your pain in your Achilles tendon or at the back of your heel? Well, in this video, I'm going to explain why you don't have to pay too much attention to the fact that you've got a Haglund's deformity, and why you can absolutely get yourself better and pain-free without doing anything to that bony prominence in the back of the heel. So for those of you who don't know me, my name is Maryke. I'm one of the physiotherapists from treatmyachilles.com, where you can get online physiotherapy assessment as well as treatment, all via video call. So have a look at the description of this video if you want a link to our website. Okay, so what is Haglund's deformity? Now, in this x-ray, you'll notice that on the back of that heel, there's a bony pointy bit there, and then also some bone at the bottom there. Now, the top arrow is pointing to the Haglund's deformity, and that's quite a small one. You can get it a little bit larger than that as well. And the bottom one is pointing to calcification in the tendon. So just there where the Achilles tendon is attaching, it started forming a little bit of bony bits in there. So how does it normally happen that you're diagnosed with this? What happens is you develop pain in the back of your heel and you go to the doctor. The doctor says, let's do an x-ray. They do an x-ray, comes back like this, and the doc says, you've got a Haglund's deformity. That's the cause of your pain. Well, not really. Let me explain to you what is causing your pain. So that bony bit on its own is not painful. It's just there. It's the shape of your bone. Okay, so that doesn't create pain. If you look at an MRI scan, the pain you feel in your back of your heel usually at that point is coming either from the Achilles tendon, insertional tendinopathy, or from the bursa behind the tendon, which is called the bursitis, when it becomes inflamed and sore and painful. You can have either of those or both of them at the same time. Now, why am I saying that the Haglund's deformity is not the cause of that pain? So let me explain to you why people tend to think it is the cause of the pain. So the theory is, you've got the bony spur there, or the Haglund's deformity there. So if you can picture this as the back of my heel, if I go over my heel like when I walk, can you see that the Achilles tendon pulls tight over there and it causes compression? And that's quite normal and happens in all of us and isn't painful in itself. That bursa that's in there is meant to stop friction between the tendon and the bone. And again, so that gets compressed every day with every step you give, absolutely normal. Now, the idea why people say the Haglund's deformity can cause pain in those structures is because it can decrease the space you have in the back of the heel. So you're more likely to compress it in that position then. But now, here's why I say, and there's quite a few people who agree with me on this in the research, it's not necessarily the cause of that pain, because you can get somebody who's been diagnosed with a Haglund's deformity. If you x-ray both feet, have it in both feet. They're shaped exactly the same, but they have pain in one foot and don't have it in the other foot. Also, that Haglund's deformity is not something that forms overnight or in a week or in a month even. It would be there for years and years and years without causing trouble before one day you now develop heel pain. Then also, you get lots and lots of people with insertional tendinopathy plus bursitis, because remember, that's the structures actually causing the pain in there, not the deformity, who doesn't have a Haglund's deformity. So there's three reasons why I say it's not necessarily the cause of your pain. So what, if I'm saying it's not, why do you then have the heel pain there? It's a classic case of overload. So if we think of this, your Achilles tendon as well as your bursa is used to receiving a certain amount of compression load. And the body is brilliant at building the structures up to cope with that. So you're walking around, running around, doing your runs and stuff, no issue. But now, if for some reason you make a sudden change in your habits and you massively increase the amount of compression that this part is under over a period of time, it will be too much for it because you haven't given it time to slowly build up to that point. And that's when it flares up. Now, what type of activities can cause it to suddenly overload and suddenly say, whoa, this is too much compression to what I'm used to? Classic one that I see, and this is in non-runners as well as runners, is when they move from wearing a shoe with a bit of a heel to flat shoes. So if we think of regular people, non-runners, it can be when you go from winter shoes to summer shoes, so flip-flops or walking barefoot a lot. So now your Achilles tendon and bursa was in this position the whole time. So you can see it's not going to get that much compression over there because it's not pulling that tight. But now you go to flat shoes or to barefoot, can you see that the compression is now going to increase suddenly? Now, if you make that switch slowly and you've built up to it, absolutely fine, because the body then has time to adapt those structures and cope with it. For runners, it'll be if you go from a shoe with quite a bit of a heel drop, so heel toe drop, to minimalist shoes, for instance. That's one of the most common reasons why I see in runners why the insertional Achilles can flare up. Another common cause can be if you do a lot of walking on flat and then suddenly you add in a lot of hill walking, because walking up the hill, again, you'll pull that tight and you increase the compression there. So massive increase in compression forces. Or in lockdown, what we've seen a lot is suddenly people are working from home. So now you have all this free time because you're not commuting. So you can increase your exercise dramatically. And it can be that you walk a lot more than what you used to, same distance than what you used to, same route, but just more often. Same thing for running. You're used to running 3 times a week. Brilliant, I've got time for 5 or 6 times a week now. But guess what? Your structures hasn't adapted to it. So yes, the Haglund's deformity decreases the space there, and it may predispose you to being more sensitive to increased compression forces, but it's that sudden increase in load of the compression forces that causes it. So how do you get it better? Do you need surgery to take that Haglund's away? Well, I hope from the previous bit you would have realized that no, you don't really. Because, and the reason I say that is, 1, you would have had that Haglund's deformity for years without pain. And 2, I've seen plenty of patients get better with a Haglund's deformity, back to full sport, still have the Haglund's there. So it obviously wasn't the main issue there. So how do you get it better? We treat the bits that's causing the pain. So if we think it's excessive compression when the foot goes into dorsiflexion that's causing the irritation in the Achilles tendon as well as the bursa, we want to take that compression off for a little bit. So for a short period of time, we may get you to only wear shoes with a heel on it. So regular trainers, for instance, or even put a heel lift in your shoe so that you don't go into that areas where it compresses. And that may mean that you've got to wear shoes for a short period of time in your house until it decides to calm down. How long that period of time is will depend on how sensitive yours is, how long it's been irritated for, and a lot of other factors around that. So that's the first step, is offload it, get it out of that position. Second bit on that as well, you'll often find that then other activities like squats and stuff in the gym can flare it up as well because it causes that dorsiflexion. So lifting your heels with that, so putting a plate under your heels when you squat, brilliant way of continuing squatting then. Then the second bit will depend on whether it's a bursitis or a tendinopathy or the combination. If there's a bursitis involved, then using a short course of anti-inflammatories may be useful for it to calm down more quickly. But remember to check with your doc because you may not be okay with taking anti-inflammatories. There may be a reason why you shouldn't take them. Anti-inflammatories doesn't help for tendinopathies. What we know from the research is that tendinopathies don't really have a massive inflammatory component to them. So don't take it just for healing, for a tendinopathy. It's only if there's a bursitis that you could try a short course. But when I say short course, 5 to 10 days, but check with your GP. Then also, if a bursitis is really, really, really persistent and does not want to calm down, there are certain injections that can be useful for it. But those are only as a last resort, because usually for bursitis, they will inject corticosteroid into the bursa, not the tendon. But the bursa is really close to the tendon, and we know that corticosteroids is not good for the tendon. And you can't keep it to just the bursa. There will be a little bit that spreads to the tendon as well. So it's a last resort if the bursa doesn't want to calm down. Usually what we find is for our patients, if we can offload it okay with the shoes, they don't need any of that. The next bit with offloading is to stop stretching your calf and your Achilles and into dorsiflexion. So I was really shocked once again, when I Googled Haglund's deformity to see if I could get nice pictures for this talk, to find how many articles of people who claim to know how to treat this tell them to stretch. So that typical calf stretch for the runners, or put a band around it, pull your foot towards you. Now, can you see that if you're going to stretch your foot like that, all it's going to do is increase the compression, increase the load on those structures that's sensitive and doesn't like compression, and it's going to be like poking a bruise. So your pain's just going to escalate and it's just going to get worse. So please, if you're doing calf stretches for an insertional tendinopathy or bursitis or Haglund deformity that you've been told for is causing the pain, stop stretching. That's one of the best things you can do, is just to stop stretching and get yourself into a shoe that doesn't cause that drop. And you'll be amazed after a couple of weeks how much your pain decreases. Now, we do need, once that acute pain has settled down, we do need to start loading it up gently. But when it comes to this condition, it's not the first thing you need to rush into. You need to get it to calm down a little bit first, okay? So when we do start loading it, it's going to be with heel raise type things where you go up in your toes, but it's going to be different from your mid-portion Achilles tendinopathy. You're not going to load it over the side of a step, because can you see if you drop your heel over the side of a step, you're going to get that compression again and it won't be ready for it. So we may opt for things like isometrics where you just hold it, or doing your heel raises but doing it to floor level. Sometimes I get my patients who are really sensitive to start going up and down but with a shoe with a heel on. So we're really limiting that range of motion where we strengthen it through. And then as you get stronger, as it calms down, as it starts to accept more compression, we bring it into more positions where it's more compressed. But it's really useful working with a physio to know and understand when to make those transitions, because if you do it too quickly, then you'll just flare it up. So these things are not stuff that needs to be thrown at it all at once. It's a stage by stage process of, okay, it's calmed down for this now, let's add that. So that's how I get my patients back from an insertional tendinopathy and a bursitis with or without a Haglund's deformity. Now, yes, of course, it won't ever treat 100% of people. And there are some cases that eventually go on to surgery and does well with surgery. But why is it that some people don't get better? So one is that it could be that your Haglund's deformity or bone spur or stuff is just so severe and so big that it does poke directly on that tendon. And because of the shape of your foot and everything else, it just doesn't get to a position that we can get it to not do that. So in those cases, it may be useful to shave that piece of bone off. Second, what I often find is that people just don't offload it for long enough. So they don't give it enough time to recover and calm down. This is not something that you can say, oh, I offloaded it for a week or two and now it's still not getting better. Achilles tendinopathy and bursitis takes at least 3 months, 12 weeks to show good improvement. And then it can take up to 6 months to get back to where you want to be. Now that may sound long, but listen, recovery from surgery isn't any shorter. So please don't see surgery as a short-term solution. If you're going to have surgery, depending on what they do, you can have long-standing recovery after that. I'm working with people who still a year later after surgery for this type of thing is not much better than what they were before the surgery. So, but then I do have other people who is massively better. So don't take it as surgery's always a bad thing. It's just about make sure you really follow the guidelines properly before you decide to go on to surgery. Also, I would go for other things first before surgery. So if rehab and offloading's not worked, consider shockwave, especially if it's an insertional tendinopathy. I've had good results with patients with that when it's not wanted to react to the treatments, the other types of treatments we've tried. Another one that could be useful is if you try different types of injections. There are different things that clinicians can do. So PRP doesn't seem to work that well at the moment. I don't think they figured it out properly. Bursitis seems to react well to corticosteroid, but like I said, not the first instance to decide to do that. I wouldn't go for steroid into the Achilles tendon. That is, in my books, a little bit irresponsible because it does predispose you to Achilles tears. But there are high volume injection type injections, and there are other injections that's experimental, that's coming onto the market. And if the risk is low with an injection, I would always try that first before you go on to surgery. Okay. Oh yes, and then the other thing is, again, why it may not work, conservative treatment, is if you've just neglected it for too long. So you've taken months and months and months that you've just kept on annoying it, didn't follow the right treatment advice, so that the bursa may be a bit thickened and there's just no way that it can be offloaded, or that it becomes happy to carry load. So in those cases, taking the bursa out can be a solution for it as well. So let me know if you've got any questions. And if you need more help with your injury, you're welcome to consult one of us via video call. The link is top of this video, but also in the bottom in the description. Take care.